I'd like to hand over to the panel of experts that we have here today. First gentleman is Professor Callum Fraser, who is a professor at the University Hospital of Dundee. And we then have Dr. Ian Godber, who is a consultant clinical scientist at the NHS Lanarkshire Hospital Trust. And then we've got a colorectal surgeon, Mr. Paul Skaith, from the Aintree Hospital Trust. So Callum, if I could ask you to lead the session.
Thank you very much, Matthew, and it's a great pleasure to see you all here. And this is an industrial sponsor workshop, so it's a workshop, and we hope that you will do some of the work. The presentations that Paul and Ian and I will give will be quite short, plenty of time for discussion, and we encourage you to ask questions which we'll try and answer or try and stimulate some discussion. So today we're going to talk about the NICE NG12 guidelines, and you'll remember that these are very all-encompassing about all types of cancer, but here we're going to talk about lower gastrointestinal cancers, because this is still a very important area. In the UK, the last year figures are available as 2013, and 26,000 and odd people died of bowel cancer, the second most common cause of cancer death, and over 40,000 were diagnosed with bowel cancer. So it's a major clinical problem for us. So up until 2015, life was wonderful. It was happy days because, as you know, the NICE at that time said no examinations or investigations. This is patients with abdominal symptoms in primary care, remember. No examinations or investigations other than abdominal and rectal examination, full blood count are recommended. And the Scottish Sign group, the Scottish Intercollegiate Guidelines Network, said much more clearly, fecal occult blood testing is too insensitive to be used in guiding investigation of symptomatic patients. And our colleagues in the BSG said fecal occult blood testing is of no benefit in the investigation of iron deficiency anemia. And of course at that time the test that these guidelines were talking about was this, which you're all familiar, the traditional low sensitivity guaiac-based fecal occult blood test. However, in 2015 everything changed, and NICE issued the Suspected Cancer Recognition and Referral, the NICE guideline NG12. And for colorectal cancer, they said, refer people using a suspected cancer pathway referral, and that's an appointment within 2 weeks, for colorectal cancer if age 40 and over with unexplained weight loss and abdominal pain, age 50 and over with unexplained rectal bleeding, age 60 and over with iron deficiency anemia or changes in their bowel habit. And this is the new thing that has caused all the consternation, confusion, controversy. Tests show occult blood in the faeces, and I'll describe in a minute the groups who should get, according to NICE, tests for occult blood in their faeces. The guidelines go on, of course, and they say consider a referral in people with a rectal or abdominal mass, consider a referral in adults aged under 50 with rectal bleeding and the following unexplained symptoms or findings. And then the crunch is this: offer testing for occult blood in faeces to assess for colorectal cancer in adults without rectal bleeding who are aged 50 and over with unexplained abdominal pain or weight loss, or are aged under 60 with changes in their bowel habit or iron deficiency anemia, or are aged 60 and over and have anemia even in the presence of iron deficiency. You will note that the guideline actually says testing for occult blood in faeces, and that is subtle. It's not fecal occult blood tests, it's testing for the presence of occult blood in faeces. And we can do that, of course, in a variety of different ways. Tests for occult blood in faeces are really, for us clinical biochemists, tests for the presence of hemoglobin in faeces. And this can be done using the traditional black fecal occult blood test with which you're all familiar and is currently used as the initial test in the screening programmes in the 4 UK nations. There is a sensitive guaiac-based SFOBT, which people in this country don't know much about because they think it's not CE marked and it's not available, but it's widely used in the US. This is high sensitivity guaiac FOBT. And then there are the much more interesting fecal immunochemical tests for hemoglobin, which are usually called FIT, and these can be qualitative, and there's a huge variety of qualitative FIT around, which use either immunochromatographic test cassettes or strips. And then, much more interestingly, there is the quantitative ways of measuring the actual fecal hemoglobin content by automated immunoturbidimetry. So, as you know, considerable negativity was expressed after the NICE guideline was issued about the use of guaiac FOBT in these very low-risk patients, principally because guaiac FOBT have very, very low positive predictive value and negative predictive value. But there is, as you'll hear this morning, ever-growing evidence that FIT are very useful in assessment of patients with lower abdominal symptoms as a rule-in test for cancer, very good, but much more importantly as a rule-out test for significant colorectal disease, which is cancer, higher risk adenomas and inflammatory bowel disease. At the moment, NICE have set up a diagnostic advisory committee to look at the literature and make some recommendations on the use of FIT. But at the moment, before the guidance is issued in April 2017, there's certainly much professional discussion and debate amongst laboratory professionals, gastroenterologists, colorectal cancer surgeons, healthcare professionals, very widely. How can we get fit? However, questions do remain, and I'm sure that you have lots of them, and we'll try and answer some of them and discuss some of them in this session today. So I'll hand over to Ian.
Okay. Thanks very much, Cal. I'll just start. There we go. So I just want to spend about 5 minutes just explaining some of our experiences of using FIT in symptomatic patients in Lanarkshire. For those who don't know where Lanarkshire is, it's the bit in the middle between Glasgow and Edinburgh, kind of middle of nowhere. So should fecal immunochemical tests for hemoglobin be used to help decide on patients who have lower abdominal symptoms, and do they need a colonoscopy? Okay. So these patients have symptoms and they're currently being referred from primary care into secondary care for colonoscopy. So we want to know is, does FIT add to this? Can we use it in triage? Okay. So we want to measure FIT. I'm trying to see this at the same time. Can we measure patients referred for lower GI endoscopy from primary care? Can patients at higher risk of cancer be triaged quickly? And we used the HM-JAC, which is one of the quantitative immunochemical methods for measuring fecal hemoglobin. That's the simple sample picker that we gave to patients, and they returned this in first-class post, and these samples were placed on an automated analyzer to produce the FIT results. This was a paper that we published based on these results. This was published last year in CCLM. So I'll briefly go through what we found. We had 909 patients. They were referred to us, and these had various GI symptoms. They were sent sample pickers, and of these, 484 patients had a lower GI endoscopy. So we were able to compare the outcomes from the endoscopy with the FIT result. That table just shows you some of the outcomes. The key message is of these, there were 11 cancers, 19 high-risk adenomas, and this tends to fit with the incidence of colorectal cancer in the UK. We defined colorectal cancer, high-risk adenoma, and inflammatory bowel disease, or colitis, as the group of colorectal conditions for which colonoscopy was deemed a benefit. We need that for diagnosis. This was the diseased group. And hypoplastic polyps, diverticular disease hemorrhoids were classed as less important findings, and these were classed as the non-diseased group in this case. So the key message is we were using a cutoff of 10 micrograms of hemoglobin per gram of faeces. And with a cutoff of 10, even then, all the cancers that we detected had fecal hemoglobin concentrations in excess of 150. They're a clear, separate group. There's a good negative predictive value as well, 96% negative predictive value. So in this setting, with a high negative predictive value, a negative result does actually provide good evidence that the patient is unlikely to have significant colorectal disease. So we've essentially got two aspects here. We've got the very high hemoglobin concentrations that you could fast track straight to colonoscopy, and you've got this negative group as well. And we'll probably have a discussion about them in a little while. So it's a good rule-out test, and therefore could contribute to reducing lower GI endoscopies. So, in conclusion, there's firm evidence that fetal hemoglobin concentration is related to disease severity and the future risk, and there's growing evidence that FIT is also a good rule-out test. There are a number of papers published, well, there's a few papers published over the last couple of years that certainly there's evidence building towards this. Measurement of hemoglobin concentration on patients referred from primary care should save considerable endoscopy resources, as well as the possibility of fast-tracking these patients who are at high risk of colorectal cancer straight for further testing. That's our flow chart of what we're doing in primary care at the moment, whereby we're rolling this out to practices now, so that when a patient is referred from primary care into the acute, the first thing they're done is given a FIT test. This test result is then available to the vetting colorectal surgeons as to how they want to treat this patient. Do they want to fast track them straight to test, or do they want to review them in a clinic? So in conclusion, colonoscopy is extremely useful. I'm not denying that, but there is huge demand for it. Guaiac fecal occult blood testing, as Professor Fraser mentioned a moment ago, has significant disadvantages. FIT, or quantitative FIT, does eliminate a number of these disadvantages, and this is, in my opinion, this is the way forward. So it's also got to a level now that NICE have commissioned a diagnostic assessment program review of FIT testing, and this will be published next year. So this is probably in response to the latest NICE guideline, is they've actually gone back and said, actually, we're going to carry out a diagnostic assessment review of this and publish this next year. So that's me. I'll pass on to Paul.
Thank you, Ian. My name is Paul Scape. I'm a colorectal surgeon from Liverpool, so it's Liverpool by night. Thank you to Arthur for your kind invite. I've been asked to talk about the potential impact of the new FIT guideline on primary and secondary care access for referral for colorectal cancer. So in clinical care, we are governed by time constraints all the time. And the major issue with cancer referral is it starts with the 2-week rule. So when the GP first refers the patients, the clock starts ticking. We have 2 weeks in which to see the patient in our clinics. That in itself is tough, and we still have to meet the targets, and we are financially constrained if we don't meet those targets. We have to have a diagnosis by 31 days. If we reach our diagnosis before the 31 days, then the next 31 days kicks in which case we've got to treat the patient by 31 days. So a maximum target is 62 days, but once we have a diagnosis, a decision to treat, We then have 31 days in which to get the patient treated. That may be surgery, it may be chemotherapy, radiotherapy, it may be palliative care, but we have time constraints at each step of the way. So if we're going to introduce a new target or a new safety mechanism or a new quality mechanism, then it's got to fit in with these time constraints. And what NICE, I think, have failed to do initially is to actually factor this in and put this in the old system. So we still have the same kind of time constraints here, but with a new test to also evaluate. So within the 2-week rule, we looked at, if you look at the old literature, if patients fulfill the 2-week criteria, then there's various literature which suggests how many cancers are picked up within. So it's between 9.4 and 16% of patients who meet that criteria will have cancer. So you've got in excess of 70% who are not going to have cancer, but will go through the diagnostic pathway. This obviously is significant demand on any particular trust. And if you look at the 2013-14 data, there's in excess of 200,000 fast-track referrals. Significant financial consequence, impact, and on human resource, certainly of our healthcare. This is a paper that wrote in 2012, and it came from Aintree. And we looked at patients who were admitted without rectal bleeding through our fast-track system. Each patient then had a fecal hemoglobin concentration, fecal hemoglobin test at the point of care, and they were actually diagnosed as fecal a fit, positive or negative based upon that test. And the cut-off at this point was 8 micrograms per gram. This is the test is OC-Samtolite. I hope you can see it at the back. The test on the left-hand side of the screen is a positive test, and that on the right of the screen is a negative test. And they were determined at the consultation to be fit, negative, or positive at that point. And out of all the cases we had, which was 137, I think it was, we had 17 cancers in the fit positive group, but none in the negative group. We also had a fairly significant disease, squamous cell carcinoma, adenomatous polyp, and a variety of other stuff. But the important thing is we didn't miss any cancers in this group of patients. So, in essence, if you fulfilled the 2-week criteria and you were fit positive, then you had a 60% chance of having a cancer. So that's a reasonable buy-in result. But more importantly, as was alluded to before, it's a good rule-out test. The negative predictive value, at least in this series of patients, was 100%. So if you fulfilled the 2-week criteria and had a negative test, then you didn't have a cancer. So looking at the clinical impact here, is it a discriminatory care test in secondary care? Well, it appears to be, at least from our data back in 2012. A negative test does not, it says that you don't have a cancer. It doesn't say what you do have, but it says what you don't have. And we feel that how this is going to impact, or the potential impact on this, is to decide what sort of test the patient's going to have. It may be that the patients have still got symptoms and will go for a colonoscopy, but with the time constraints that are there in clinical practice, it just means that they don't need that colonoscopy within the 31 days for the diagnosis. So, as a clinician, it's very important in that case that we're able to say who has a timely scope, who requires one straight away, who requires one certainly within a couple of weeks, and who doesn't. We can look at symptoms, perhaps we can retest, perhaps other forms of test, perhaps they'll go on to get colonic imaging anyway, but it just doesn't have to be within that time frame. So, the extension to primary care, could we take this one step further? Does this test belong in primary care? Can it be discriminatory to say who should be referred in the first place? At the moment, the gate where it's coming down in secondary care, no, this patient doesn't require any further urgent imaging, but could this be referred out to primary care? So does this patient actually need a 2-week referral in the first place? So, as far as you can see, for all the data that's available, the science fits. The fit is a good test, and the science is there behind it. It's the applicability. Where does this test belong? So, we looked at before, at qualitative analysis with a cut-out value, that will give you a value there and then. But quantitative analysis is more interesting. It's certainly a more subtle, more refined way of looking at this. But there's an inherent delay. If you send off a sample, does the referral go on hold, or we have to wait for the fit sample to come back here to say, yes, this patient's going to be referred on or not? And that's a question I think that we're going to have to answer. Slightly clumsily, I think that's why I'm nice of re-looked at what they're doing here, because the whole guideline, the whole pathway is an old pathway with now something else bolted onto it. The science is behind it, it does work, it's just where it fits in. Does it fit in primary care? Does it fit in secondary care? Is it the axis between the two?